Hey all, Eric Christensen, pharmacist with you today. I've got a really special episode in line for you. Recently I recorded a brand new lecture which I added to all of our study materials for BCPS, NAPLEX, so on and so forth. So again, this is 15 minutes of 25, 30 plus hours in some cases, depending upon the study package that you're looking at. So information presented here is going to be on continuous glucose monitors. I hope you find some good clinical practice pearls on that. And of course, if you want slides and other things with it, you can stop by meded101.com/store and go check out all our study packages, which contain thousands of practice questions, numerous hours of lectures to prepare you for your board exam. So go check that out. Support the sponsor at meded101.com, and hope you enjoy this little lecture on continuous glucose monitors. Thanks so much for listening. Take care. Have a great rest of your day. All right, I'm going to talk about continuous glucose monitors a little bit. This has definitely been an area with diabetes care that has been growing and expanding rapidly. I think it's important to recognize the difference between a continuous glucose monitor and a blood glucose monitor and some of the differences there. So cost is obviously a big thing, or can be a big thing if insurance is not covering a continuous glucose monitor. That can certainly be an issue because it is significantly more expensive than your typical kind of Accu-Checks blood glucose monitoring that way. Blood glucose monitoring only gives you that instantaneous moment in time, so that presents a little bit of a challenge in trying to identify trends and when people are, dipping low and spiking high and things of that nature. One advantage potentially to the blood glucose monitor is it does not require a prescription, where a continuous glucose monitor, at least at this point, does. So definitely a few differences, and as we get into it here, I'll get into some of the kind of clinical differences in testing too coming up here. So that big difference that I think you should pay attention to with blood glucose reading, or an Accu-Check reading, it's often called, this gives you an accurate reading of what the blood sugar is right now. Whereas continuous blood sugar monitors, they use interstitial fluid, which isn't going to give you as perfect of a rapid kind of response as to what the blood sugar is doing compared to actually taking the blood sugar itself with an Accu-Check, for example. So what that means is there is some lag time. So if somebody's got a continuous glucose monitor in, and they, check them at the exact same time, there may be some lag and some variation in that blood sugar value. Now, I will say, if you look at the literature, you see anywhere from maybe to 5, even up to 30 minutes of lag time in some cases. As these sensors have gotten better and as they get better and better, I think that lag time is going to continue to shrink. And I would say for most of the meters on the market, we're in the 5 to 15 minute lag time range. But again, I think that is important to note, and an important patient education point, particularly if patients are feeling hypoglycemic. You could imagine having a situation where patient looks at their continuous glucose monitor and it says, oh, I'm at 75, I'm at 77, I'm at 80. Blood sugar must be okay. It must be something else. Well, if that blood sugar is trending down and that reading is lagging behind, that's definitely a situation where we've got to educate our patients and say, hey, if you're feeling hypoglycemic, be sure that you have a blood glucose monitor available to you as well, and follow your intuition. If you feel like you're getting hypoglycemic, you have to play it on the safe side and basically assume that you are. So definitely a really, really important, I think, patient education point there. with the difference between the continuous glucose monitor and that little bit of lag time due to the interstitial fluid compared to a blood glucose monitor or an Accu-Check reading. There is differences between the sensors, depending upon probably the biggest thing I've seen, I've heard of, I've read. Some patients may, be finicky about the location of it. So if they want it on their arm, great. If they want it on their abdomen, you may have to choose different meters based upon that. Although this is probably something that's going to change over time, where it increases the availability and the access of sites that you can place it with each monitor. But for the time being, as I'm creating this, different meters have different places that it is recommended to put them on. So that may make a difference in patients and what their selection is, as well as obviously insurance coverage and things of that nature. All right, so remember the 3 A's and hydroxyurea. Those are important ones that might come up, that may interfere. Most of these, I believe all of them, do falsely cause those sensor readings to be a little bit higher. So acetaminophen, alcohol, vitamin C, hydroxyurea, vitamin C, acetaminophen probably being pretty commonly used, and then alcohol as well certainly can be an issue with some patients too. So, and each system may be different. As you can see, I've got the primary systems affected with those specific medications or chemicals or whatever you want to call them. But that's an important thing to note. Knowing what sensor we're using and recognizing if something doesn't make sense clinically in relation to the A1Cs or blood sugar readings that they're checking. Be sure to check that med list and make sure that they're not taking acetaminophen, maybe some excessive alcohol use, vitamin C, hydroxyurea, mannitol, which not something you probably see too often, but tetracycline, there has been reports with that one as well. So just keep this in mind. If you see something wacky, I suspect you probably won't be tested on this in your exam, but I think it's a good thing to keep in mind if something doesn't seem to add up right with the sensor readings and where the patient's at with A1C and other clinical factors. So when are we going to use continuous glucose monitoring? Insulin. So, if a patient's using insulin, these can be really, really helpful devices, and stats, clinical literature has actually shown that we can get better control of patients in general with a continuous glucose monitor and patients who are taking insulin. So, really, really important to hopefully have this available as an option for your patients, particularly ones that may not be under good control. You may see it utilized in other cases, probably not shown to be as advantageous in those situations where maybe a patient's just taking an oral anti-diabetic medication for type 2. The benefit certainly isn't as great, or the evidence isn't as great at showing benefit there. But if you've got a patient on insulin, that's definitely somebody that continuous glucose monitoring can really help identify when and where we have issues, particularly in our patients that are not meeting goals. All right, let's talk a little bit about the details of what the readings show, what some of our targets are, and those type of things. So we want to make sure that that continuous glucose monitor is actually getting readings for us. So it's recommended that during the given period, usually 14-day period, we want to make sure that it's at least 70% active. Basically, that's where it's running and giving us readings so we can track and monitor glucose. And then we've also got a value called the glucose management indicator. Essentially, that's an estimate of A1C. And then we've got variability. Obviously, we don't want somebody that's spiking super high and spiking super low. Whether they have a continuous glucose monitor or not, we don't want that. That's very difficult to manage. It's very hard on the patient, leads to hospitalizations, ER visits, and so on and so forth. So we want that variability in that blood sugar to be low as well, and that's defined as less than 36%. Now, time in range, 70 to 80, that's the good range that you really want to remember. That's what we're targeting. And we want that to be 70%. And I've got some of the goals on the next slide here. But ideally, that 70 to 180, that's our target range. We want patients to be in that range at least 70% of the time. Then let's talk about some of these other ranges. So very high, so that's classified as greater than 250, less than 5%, certainly that makes sense. We want to minimize that time. High is considered greater than 180, less than 25% there. Again, I mentioned that target of 70%, 70 to 180. In my classic, geriatric patient population, we're not going to probably be as strict about that. That time in range, we're probably going to be a lot more focused on, first and foremost, avoiding hypoglycemia, and then obviously avoiding very, very high blood sugars as well. So that goal may be reduced in some patients, let's say, on hospice, short life expectancy, that type of thing. So that might be dipped down to greater than or equal to 50%. Low blood sugars, less than 70. Goal is less than 4%, and less than 54. That's considered very low. Obviously, significant hypoglycemia there. Our goal is less than 1% of the time in that range. And you might ask, okay, why 70%? Why not 60? Why not 80? Why not 90? Well, obviously, you probably want that value in general as high as you can get it. That time in range, obviously, while avoiding hypoglycemia. That's really the ideal goal. But for this time in range of 70%, you're likely going to get an estimated A1C around 6.7. So that's usually within our goal. Most patients we're targeting an A1C of 7 or less. So that's really where kind of that target of 70% in that range of 70 to 180 comes from. So as you can see, kind of the red area, that is hypoglycemia. We want to avoid that. Again, that's less than 4%. If they dip below 54, that's less than 1% of the time. And then we've got spikes above 180. So this patient obviously has quite a few spikes above 180, but they also have quite a few hypoglycemic episodes as well. So this is a patient where it's like you're probably going to look at these values, see where they play out, depending upon what they're taking, what they're doing. Maybe they're taking, a mealtime insulin, for example. Maybe they're just taking a basal and they're dipping down early in the morning or late at night. One of the cool things about this that, we, at least as a clinician, it's like you historically don't really think about it too much, but the day-to-day variation, depending upon what that patient is doing. So as you can see, Friday and Saturday are pretty not so good days for being out of range. I mean, they are out of range most of the day. They're above 180 most of the day in this situation on Friday and Saturday. And so that's a really, really neat thing to be able to identify and helping to educate the patient. It's like, okay, you probably shouldn't stay up until 2 a.m. and eat everything in sight, or whatever the case may be, depending upon when those values play out. But this gives you that opportunity to really see that play out kind of in real time and in real life, and recognize where those huge spikes are and why we're having so much time out of range even when maybe the rest of the week, when they're in their work routine or whatever the case may be, maybe they're pretty good in that area and stuff. So, looking at that hypoglycemia, there may be times, a situation where we reduce insulin in that setting. Maybe this patient is spiking postprandial, so maybe we do something there. If it's a type 2 diabetes patient, maybe we add a GLP-1 agonist to help target that postprandial, and then maybe we reduce the insulin a little bit to try to reduce that hypoglycemia risk. So kind of whatever the case may be, whatever the situation may be, we can use this data and when patients are spiking to ideally try to tailor their insulin, their diabetes regimen to the best that it can possibly be. So hopefully that gives you a little background on continuous glucose monitoring and how we may use this to help adjust our diabetes medication regimen. Thank you so much for listening today. I hope you enjoyed it. Hope you found some clinical practice pearls that you can use in your practice. As always, go check out meded101.com/store if you want the PDF slides on this, as well as access to over 100 different lectures on various topics pertaining to the various board exams. So we've got NAPLEX content, BCPS, ambulatory care, geriatrics, BCMTMS, and multiple other avenues to learn pharmacology as well and pharmacotherapy. So please go support the sponsor, meded101.com/store, and I thank you for listening today.